morning, thank you. And I'll speak a little bit about spine deformities in MMC. So we all know that spina bifida is a spectrum of morphologically defined malformations, which can vary, and it's sort of a cultural thing. We still see it quite oftenly in Israel because of the population, because of a lack of abortions to these kids. So the demographics, once again, it depends on where you read it and in which country you live in. But according to the literature, it's between 0.1 and 0.2%. The risk factors, we all know, the major one is the folic acid deficiency, but also maternal hyperthermia, maternal diabetes, and lack of valproic and maternal assumption of valproic acid. There is some genetic predisposition. It can be with chromosomal abnormalities, as regarded as written here, trisomy 13, 18, etc. The classification defines on the clinical appearance, whether it's just spina bifida occulta or meningocephaly without the actually the neurological elements going out, or the more severe myelomeningocele form. The natural history, when it's untreated, is actually mortality is almost certain in 90 to 100%. And if you see them at the age of 2 months and they were still not treated, then they have a latency to not to pass the 7th year of life. So the challenges are firstly the neurological complications. We all know the neurosurgical difficulty in closing that defect, the hydrocephalus and the Chiari malformation that are mostly related to this condition, but also the urological problems with incontinence, impaired bladder, and reflux of these patients, and all lead to frequent of infections due to these urinary problems, and up to even reached renal failure. Other problems are the skin, but for us as orthopedic surgeons, we see them with kyphosis or scoliosis that can reach 50 to 90% of the kids, hip dislocations, knee contractures, rotational deformities, foot and ankle deformities, and of course, don't forget the osteopenia. Also, these patients have a IgA-mediated latex allergy, and also always when you perform surgery on these patients, remember that they should be latex-free. So we're talking about a multiple system involvement regarding the orthopedic problems. So it's not only the spine, it's the pelvis, the hips, the contractions, it's the brain problems that they have with the hydrocephalus and the Chiari malformations. Many times they have pulmonary problems, nutritional status, their immune system. So we're talking about very sick patients with the spine problems when we treat them. The scoliosis is linked to the neurological impairment and to the growth potential, and of course to other vertebral anomalies because it's a defect in the formation. So many times we can see congenital scoliosis with this problem. We know that the greater the neurological compromise, the greater the likelihood of developing scoliosis, and it's regarded as the level of the neurological impairment that you have. As you can see here in this chart, the likelihood of having scoliosis in these patients rises as the level of a neurological impairment is higher and more proximal. The types of spinal deformities that you see it differs. It's not a single deformity that you see in these kids. It can be the typical neuromuscular type of scoliosis, and it could be with scoliosis with lordosis or with kyphosis, and it's very important to define them, these three characters, because we treat them somewhat differently. It can be the congenital type, if you have also congenital scoliosis and congenital malformations of the vertebral column, or a pure kyphosis with that typical gibbous that you have in these kids. The goals of treatment is to prevent further deformity and further deterioration, to prevent and to treat pressure ulcers, to level the pelvis, and to create a stable and balanced spine to these handicapped patients. And once again, they will remain handicapped. You are not treating their basic neurological function. So as always, we begin with a conservative treatment, trying to delay surgery with non-operative treatment, such as we begin with observation. Always observe these patients, even if they don't have marked deformity at the beginning. Then trying to help them by sitting support or orthosis, but the main treatment usually deteriorates and reaches the operative treatment for us as orthopedic surgeons. When you have a neuromuscular type of scoliosis, so if it's scoliosis, it will be treated by a standard posterior instrumentation, and usually you should go to the sacrum or the pelvis, but this is questionable. Once again, it depends if you see already pelvic obliquity or not. Usually you will see it. If there's a kyphotic deformity, then conventional instrumentation and fusion, once again, mostly by posterior, or sometimes you will have to do a combined, but this is rarely. Combined, I mean anterior and posterior. And once again, try to go to the pelvis most of the times. If it's a lordotic problem with the scoliosis, then it's a more challenging situation. You should treat first the scoliosis via posterior approach, and this is unlike what we do in usual and most cases. When we say combined cases, we usually begin with the anterior, then go to the posterior. In these kids, you have to start with the posterior fusion and only then go to the anterior and perform the anterior fusion in addition. If you have a congenital type with congenital scoliosis with any kind of congenital malformations, then you can think about doing in situ fusion if it's not a very profound and severe deformity, or perform more staged procedures like convex epiphysiodesis if it's a very young patient, or if you have a really isolated hemivertebra, to do a resection of that hemivertebra. If you have a segmental defect, then you have to think about doing a resection type of surgery. Now we'll start going over the different options with showing cases. And once again, we'll see that it's not only regarded to the deformity itself, but also to the age of the patient by choosing the proper treatment. So if you have a kyphosis deformity, isolated kyphosis deformity, then you should think about performing a kyphectomy. But the question here is regarding the timing, whether you do it by resection, full resection of that gibbus, or you do an eggshell procedure. And if you do a fixation, will it be a short fixation just of that gibbus or a long full spine fixation to the pelvis? Depends on which level that gibbus is. And once again, so we'll show a few cases. So this is a typical neuromuscular type of scoliosis at the age of 13 years old. The patient is non-ambulatory with a pelvic obliquity. So in this case, the classic procedure would be the neuromuscular type of procedure, going posterior spinal fusion from the upper thoracic level and fuse it to the spine in order to achieve a balanced pelvis, and good fusion from posterior will be sufficient. When you have the same type of pattern, so a neuromuscular type of scoliosis, but at the age of 6 years old, then a long fusion is not an option, because we know that performing such fusions in a too young of age is creating more problems, or doesn't solve the problem, because you're creating the problems by yourself. Even though you thought that you're solving the deformity, you're creating the restrictive lung problems. So in this case, we would we would use growing rods without going to the pelvis, because this guy walks with RGOs. The level is pretty low. It's about L4, L5. So he's able to walk. So we would just stay at L4, L5 at this, with these magic growing rods. If you have a neuromuscular type of with lordoscoliosis, then once again we would perform a posterior spinal fusion with the pelvis. If you would get enough correction, there's no need to go anteriorly. If you don't have enough correction, then you would have to go anteriorly, do a small osteotomy anteriorly, and create a fusion in the lumbar area going anteriorly in these patients. But usually you would stage it, and you will see the amount of correction you have and the quality of bone fixation that you achieve by the posterior fixation. If you have, as we said, a pure kyphosis with a typical gibbous at the age of 15, then what we would do a kyphectomy. As you see here, I don't know if it's so clear, but here we're underneath the spinal column. We are underneath the vertebra. This is the cord. This is the posterior side. This is the anterior side. So you actually you see that, and you resect it. You resect the gibbous, and you create a fusion between the bones above and below. In former times, it was said that you have to suture the cord and to cut it. But actually, in the 3 cases I did up till now, we didn't do it anymore. You don't have to do it. You can preserve the cord for what it stands, and by this you just avoid CSF leaks and maybe the problems with a shunt if they have, because most of them have hydrocephalus. So if you can prevent it, it's better off, and you fuse it then after resecting these 2 or 2.5 vertebrae and using that as bone graft, and you have a very nice correction. But if you have the same pure kyphosis at the age of 3, this can cause an argument. There would be people saying that it will not cause a restrictive problem, so you can go ahead and resect and do a kyphectomy to these patients. That's an option. This is something of debate, so it's an option. What we preferred to do in this case was to try and still use the magic rods, and you place them actually just in front because of the sharp gibbous you have there. Actually, the rods themselves are a little bit anteriorly, as you can see, are anterior to the spinal column. So by distracting them, you're creating a lordotic effect and not a kyphotic effect, as usually you have with growing rods. So this is something that is not, it's debatable, but I would think that this is a better solution. But that's my personal opinion. Another option is to use a bilateral vector, or what they call a two-Eiffel construct, with having the vector on the pelvis on both sides, and then allowing to level the pelvis and to continue growth of these patients. It's highly popular still with MMC patients. The only problem is you have to do repeated surgeries. There are now people, especially in Germany, who are doing a combination of magic rods with a vector, and by this allowing the same pelvis balancing without the need of repeated surgeries as you used to have with the vector constructs. Leveling the pelvis itself is a great challenge, and I think that this is the major goals that we are trying to have in this surgery. And what I use in most of the kids, in these kids, is the use of a hollow femoral traction during surgery. And by this, you really have at least 60 or 50 or 70% of correction already before you even begin surgery. You place them with either a halo or a glison or something, tongue to the skull, and you put the femoral pins and you put weights, and then you slowly stretch out. It eases your exposure. The correction is more gradual and less acute, and it allows you most of the cases to achieve good correction with only posterior release. These patients have a lot of complications. Their complication rate is very high, up to 40 to 90% of the cases will have a complication. The major one, of course, is the infection and this is due to mostly to their urinary problems. But there are also implant fixation problems because of their one issue is their poor bone quality. So you have okay, 2 minutes. You have a high rate of pseudoarthrosis and dislodgement of the implants, but also the implant profile is very, very important because some of these kids are really skinny and you have scars because of the neurosurgical procedures they had before. So it's a problem. Skin problems with decubitus ulcers is also a problem, and don't forget that many of these patients you will have hip contractures, and this will raise problems with sitting after you straighten their spines. So in conclusion, this is a tough situation to treat with due to poor both bone quality and tissue quality. You have to take urine cultures prior to surgery and to treat them even if they have silent UTI, and most of them do have silent UTI. You have to use proper prophylactic antibiotics, which will usually be wide spectrum. We usually use 3 types of antibiotics. We use cephalosporin second generation, we use Flagyl, and we use gentamicin during surgery. The current trends are all posterior, mostly all posterior fusions with corrections. We use tibial allografts or autografts, but other people use allografts or BMPs. Use aggressive instrumentation construct because of their low bone quality. So you have to really not rely on a very short construct or a very small implant rate, but you divided the loads on as many screws as possible. Use the most low profile instrumentation as possible because you would otherwise run into skin problems. And if you have to perform circumferential fusions in these patients, then unlike other cases of scoliosis treatment, you do the posterior spinal fusion first, and only then you do a delayed anterior spinal fusion. Thank you.
Thank you, Dror.